3 years now. In our practice, we also have Dr. Evan Lose, who joined us 2 years ago, and our nurse practitioner. We have 2 nurses, and we provide pediatric endocrinology to our region. One thing that we provide that's unique is care to transgender teenagers and sometimes transgender youth. So we're going to kind of look at a couple things today. This presentation was originally like an hour and a half, hour and 45 minutes, so I've tried to desperately trim it down to be an hour long. But we're going to kind of look at several things that kind of come into conflict a little bit in transgender care, and those things are law, parental authority, and adolescent autonomy. And so we're going to explore that a little bit as we go through a transgender case. I have nothing to disclose. Okay, so we have a couple objectives here. First, we're going to explore the kind of the ethical basis of respecting adolescent autonomy in medical decision making. I'm going to go through kind of what we do with hormonal suppression, explain that a little bit more to you, as well as cross-hormone therapy and some of the criteria of when we do that and how we provide that service. And then we'll kind of look at all these ethical conflicts that arise, which will become very obvious as we go through the case. And this is very common. In fact, I had 2 transgender patients just 2 days ago, and several of the elements of this presentation mirror what just happened in those particular clinical encounters. So this is going to be our general outline. We're going to start with the case. So first, just kind of giving you the definition of gender dysphoria. It is an incongruence between one experienced gender and the gender to which the person has been assigned. So we usually refer to the gender that person's born with at birth as their natal gender. So we might say someone is a female natal gender but identifies as male. One thing that we don't have a lot of time to talk about is literature that talks about pre-adolescent gender dysphoria. That's a whole nother talk. But what you should know is that generally there's a lot of fluidity during that period. In fact, it's considered up to 80 to 90%. So there is controversy about how those cases should be handled. I'm not going to try to address those today. But essentially, in terms of providing any kind of treatment, for example, starting pubertal suppression, we would wait for someone to first enter puberty and to continue to persist in identifying as transgender. And then once we do have adolescents who have persisted, the general criteria is that they need to persist for at least 2 years. And that would be in consultation with a qualified healthcare professional, mental health professional, that can kind of make this diagnosis. This is a unique part of medicine for us in endocrinology in the sense that usually I can make the diagnosis and treat. In this case, I can really only make this diagnosis in conjunction with a qualified mental health professional. And that mental health professional needs to identify that, yes, indeed, they have gender dysphoria, and they need to also try to address any comorbid conditions, depression, anxiety, or we have had other very complicated cases where there was abuse involved or other things that we felt complicated the case. There's not a lot of great studies on transgender youth, but this one from 2010 is a pretty good one, kind of looking at mental health in transgender youth. As you can see, it's not so great. Over half of them have attempted suicide. 83% actually have thought about it. Self-mutilation is fairly common. Often they're self-mutilating the parts of themselves they don't identify with. So they might be mutilating their breasts because they identify as male. I've seen this a couple times already in my clinic where people are finding black market testosterone or estrogen and trying to treat themselves. And so that's a very dangerous thing. And I actually had to convince a family to let me just do the legal way so that they wouldn't be endangering their child who was going to do it anyway. People have also tried to do self-silicone injections. And then you can see in terms of trying to cope with being transgender, people often turn to substance abuse to try to cope with those things, and sexual activity is very common. So we're going to do a case here. They're going to be 15 years old. They're a natal male. but they identify as transgender, female, and they go by Mary. And she, we're going to talk a little bit more about this. This is kind of the overview, but she's been on puberty suppression since age 11 with a GnRH analog. Now she wants cross-hormone therapy, and on top of that, she also wants to be referred for gender reassignment surgery. She has seen a mental health professional since she was 11. There's been no comorbid psychiatric issues identified in her particular instance, although most people suffer on some level with depression and anxiety, and then of course some of those other behaviors, self-harming behaviors. So again, we kind of waited for Mary to first enter puberty and to persist in her gender dysphoria. We don't generally start treating with a pubertal suppressant to prevent puberty from ever starting, just because of the high rate of desistance at that time. So she was placed on a GnRH analog. This is a completely reversible treatment. If you start it and then they change their mind and you take them off, they will go back into their natal puberty. So that's the kind of nice thing about this from an ethical point of view, is that it's a reversible kind of treatment. She actually has a friend who started her cross-hormone therapy at 14, so that's why she's real excited to transition. Just as kind of a really brief review, puberty starts with GnRH pulses. They begin at night. That will lead to LH and FSH pulses. Those LH and FSH pulses will then speak with the gonads, and that's how the party begins. Basically, these pulses start in the night, but then eventually become day and night, and then you kind of go into puberty. Oh, but I just want to say, so the way a GnRH agonist is going to work is instead of being pulsatile, it's going to create a constant signal, right? It'll be initial pulse, actually, so people actually get a little bit worse in their puberty, people we try to treat for early puberty. But by making it constant and eliminating the pulsativity, you turn off puberty. And so it arrests puberty and it's suppressed. So this is designed to help teens who are persisting with gender dysphoria, who experience distress at the development of their natal secondary sexual characteristics and wish to suppress them. So at this point, Mary wants cross-hormone therapy and gender reassignment surgery. The general guidelines from the Endocrine Society were most recently revised just last year. Generally, it's always been felt that the minimum age is 16, kind of from a decision-making capacity point of view, and from the fact that this treatment actually has irreversible side effects. Okay? So we're looking for a teen who truly understands the magnitude of the decision that they're making. However, the newest guidelines do state, and it leaves it somewhat vague, that a physician may do it earlier if there's a compelling reason to do so. What that compelling reason is a little unclear. In general, pediatric endocrinologists across the country vary quite a bit in when they're willing to start cross-hormone therapy. I've seen people start as early as 13 and 14 at certain places. Sometimes it's really just left to physician judgment in conjunction with talking with the mental health professional. But there's a lot of ethical issues and legal issues that come out of trying to do it earlier if the parents aren't on board, and also trying to determine if the adolescent really understands the magnitude of the choice. Okay, so just to kind of go over some of the side effects that would happen for Mary in this case, we would be giving estrogen treatment. That estrogen treatment would be kind of going up in a kind of a sliding scale upward to help her through puberty and develop female secondary sexual characteristics. The primary goal usually is breast growth, but in terms of effects on natal mat things, it's going to redistribute body fat more in a female way, reduces muscle mass, libido, may reduce or eliminate erections. You get decreased male pattern hair loss, so there's a benefit on the bottom. And then testicular volume will start to decrease, and that will also lead to decreased sperm production. And if you're on long-term therapy, result in infertility. In the case of Mary, Mary never went through natal male puberty, so in this case, they will be infertile. because we've suppressed that puberty and now we're already moving on to cross-hormone therapy. Obviously, they wouldn't have the deepening of the voice, and then there's kind of other psychosocial impacts. Estrogen treatment is not something we should do just willy-nilly. You really have to explain to a patient that there are risks involved. By giving a natal male estrogen, you're significantly increasing their risk of a thromboembolic event. In fact, it's 20 times the regular amount. So I don't know a lot of other disease states where we would tolerate that high of a potential side effect from a medication. So I really make sure I let patients know that. These other risks are very unclear. They all come from very, very small studies. I'm talking 10, 20 patients who've had these kind of issues while on cross-hormone treatment. I think the ones that people are primarily worried about right now are breast cancer, and there has been macroprolactinoma. These other ones, it's really unclear. Patients always ask me, what is the risk? What's my risk? There's insufficient data to really give you the risk. All we know is that the current guidelines say that there is a moderate risk of those things. Okay, so that kind of gives you the case of Mary. Any questions about that case? Yes?
You talked about the 20 times increase of thromboembolic disease.
Mm-hmm.
What's the relative risk, what's the absolute risk of that in the general population? If it's increased by 20 times.
Yeah, I don't know what the general population risk. I just know that the risk for a boy on estrogen increases 20 times what it would be for a boy. So I'm not sure what a boy's baseline risk is. I'm not sure. Yep.
You mentioned that the hormonal treatment is reversible. What about that infertility? Is that a reversible consequence?
In this case, this person was on pubertal suppression, so they never underwent their normal natal puberty. And so if they continue on cross-hormone treatment, they will be completely infertile.
But if they stop taking the hormones, then would they go through normal puberty and become fertile?
Potentially. So whenever you come off the Lupron or the Leuprolide, which is the GnRH agonist, absolutely. Within a couple months, you usually would go into puberty. If you've suppressed that your whole life and then you go on estrogen, it's a little unclear how well your pubertal system will work and if you would develop normally after that. I don't know if many people have actually tried that. Other questions about the case? Okay. All right, so the next part is to talk a little bit, and this is usually a longer part of this presentation, but I've shortened it in order to fit into the time frame. So this is very typical of how this happens when people come into my clinic. It's very unusual for both parents to be in a role of supporting what the teen wants to do. Sometimes you have both parents not wanting it. In this case, the parents are divorced. Dad is very supportive of Mary starting estrogen supplementation. He feels like this is going to help with psychosocial issues, helping her feel kind of more comfortable in her own skin and who she really is. So he kind of sees it as a psychological well-being issue. Mom, on the other hand, is very opposed. She wants her to wait until she's 18. She's very, she feels like she uses the word he, but she sees him as not ready to making these irreversible changes that would happen with cross-hormone therapy. She does not feel like Mary would understand the full implications in terms of infertility and other issues. Also, from a religious point of view, Mother believes his gender is in flux and that God doesn't make mistakes and that he's going to eventually kind of figure out that he's a boy, not a girl. Also, at one point along the way, this patient also threatens to sue if therapy is completed without her permission.
So who has decision-making authority for this child?
They both have joint custody.
So
they both have shared decision-making capacity. Yeah, they both have legal rights to weigh in this case, yeah. And this is very typical. And it's very typical that there's cultural, religious, or other objections. And I try very hard to help patients negotiate those and kind of create bridges of understanding. A patient that I just saw 2 days ago, she really wants to move forward. She's 16 going on to 17, wants to start cross-hormone therapy, but the dad is very much opposed for religious reasons. And she kind of explained those, and we discussed them, and we try to create bridges with the parent in understanding kind of respecting each other's thoughts and feelings on the subject, something that seems to be lost in current political situations, but trying to really help people to meet each other and allow teens to make decisions once they're fully informed. Okay, so this is where ethical things start to come into play, right? So we've got the principle of autonomy. This teenager clearly has indicates they want to do cross-hormone therapy. They're ready to go. They've persisted in their gender dysphoria now for over 2 years. In terms of risks and benefits, there's potential benefits for mental health, reduction in suicidality, self-harming behavior, substance abuse, psychosocial well-being. Non-maleficence harms could include that the treatment itself has inherent harms, and that some of those potential harms are irreversible or only semi-reversible. And then, of course, we've got the parents. The parents are in disagreement, and the parental authority that parents have over their children to make decisions. So, kind of looking at this question, I was trying to figure out, well, what's the legal right that this patient has as a 15-year-old in Tennessee? I am not a legal expert. This is my best attempt to look at this question. And then, again, we're kind of looking at decision-making capacity. I'm sure you've all met 14-year-olds who are extremely mature that you would allow to make important decisions in their life. And then you've met 18-year-olds where you're like, wow, I don't think I would even give you my car keys, you know? So that's one of those things that gets really hard as a physician, because you really are trying to gauge, does this patient really comprehend and understand fully the implications of their decision? So where do this is kind of this is again a bit truncated, but these are the basic reasons that law and society give parents authority over their children. The general consensus is they want the best for their kids, usually. That they have their interests in heart, that they know them, they understand their needs, that they love them. We all know that there are obviously exceptions, unfortunately, to this. And then also parents bear the burdens. And this becomes a really important issue in these transgender cases, because the insurance, for example, in the case I was giving you, it's all under the dad's insurance, okay? So he would be seeing all these bills for something he doesn't believe in or agree on, okay? And sometimes these things are not well covered by various insurance companies, because they don't, when you try to do follow-up labs to make sure they're not getting side effects from treatment, they often won't cover those labs under the diagnosis code of gender dysphoria. And sometimes we'll struggle to get someone on a Lupron if they wanted to be on suppressive therapy. It's very expensive therapy, $9,000 to $12,000 a year to be on that therapy. And then we also run into trouble where some insurances will also not cover the cross-hormone treatment. So that's kind of changing, and in theory has changed. Legally, it did change under the Obama administration, but from a practical standpoint, we're still having problems with it. So this is my attempt to look at Tennessee state law. So just kind of giving a little bit of a background here, Tennessee law does not prohibit discrimination on the basis of sexual orientation and gender identity. It does punish hate crimes based on sexual orientation, but not gender identity. There are certain parts, Knoxville, Memphis, and other kind of metropolitan areas that do have protections that include both sexual orientation and gender identity. And then, we've got the Tennessee Board of Regents that does include both, but the University of Tennessee system only covers sexual orientation only. So you can already see we're getting kind of a mixed picture of how Tennessee law works. One interesting thing about Tennessee is that in 1977, a law was passed that you cannot change your birth sex on your birth certificate. In fact, Tennessee is the only state to prohibit the reassignment of one's gender on a birth certificate left in the United States. So you can change your driver's license, but it's kind of vague how that actually happens, because it says the physician has to sign off that necessary medical procedures to accomplish the change in gender are complete. I'm not sure what complete means. Complete is in they've had gender reassignment surgery, or they're finished cross-hormone therapy, or so that is very vague in terms of how I would qualify a patient to change their driver's license. One thing my patients have been able to do is go to court and just change their legal name, and that is allowed in the state of Tennessee. These are just things I found online that are allowed without parental consent. So emergency treatment, prenatal care, sexually transmitted illness services, medical care for a minor child. Treatment requiring parental consent includes abortion. So this is kind of looking at what is the capacity for a minor to give informed consent. And the big thing here is the age 16 appears to be kind of the magic age in Tennessee, because adolescents that are 16 years of age and older are presumed to have the maturity to consent for medical care, including mental health care, and can sign their own consent for treatment, services, or tests. However, none of these laws directly go back and look at, well, is that still true in the case of treatment for gender dysphoria? In theory, the answer is yes. But of course, in the case of Mary, Mary is currently 15. Let's see how I'm doing time. Okay. So again, it's a little unclear exactly how Tennessee law works in this case, but what it does suggest is that you would need consent from both parents, including the dissenting parent, which in this case is the mother, in order to move forward with treatment. You know, it's very, very common that we run into these issues, especially with parents who are divorced and have very different views of what's going on. And things get kind of complicated. I had one patient come in, and his gender dysphoria started immediately after his parents divorced. So that was very strange. And was not taking on the pronoun of the gender that they identified with, or wearing clothes of that gender, or really doing anything to move in that gender, but suddenly just immediately switched at a very late age, 16, to being gender dysphoric. So that case I handled with quite a bit of deafness and stalling because I felt there were a lot of other things going on for this kid. And it turned out the dad had come out gay and left his wife, and there was just a lot of things going on. So I sorted that out with some of the mental health professionals, and we worked on that quite a bit of time before we finally moved forward with cross-hormone treatment in that patient. Oh, and before I go too far, any questions about kind of what we just went over on the law side of things? Okay. So, I mean, the biggest thing is, again, what I said, there's really no specific laws that codify how and when adolescents with gender dysphoria can receive treatment in Tennessee. Everything's left to these other vague kind of statutes that I went over.
Are there laws in other states that codify how to treat adolescents?
Yes, there are. So the state of Oregon, where I came from before, the age is actually down to 14 for most things, including gender dysphoria. And there's some things age 12 that you can consent to in the state of Oregon as well. But, you know, if you look across the United States, you're going to get just a mosaic of different laws on all these issues. The other big issue for Tennessee is there really isn't any overarching law about protections for people who are transgender or gender dysphoric. It really only protects sexual orientation. So again, we're left with lots of questions. There's kind of physician judgment. Does the kid understand what's going on? Do they meet the criteria of gender dysphoria? Did the mental health professional sign off on it? And then try to figure out what to do to help parents who object. So now we're going to do an ethics consultation, and you're going to be the ethics committee, okay? Because I'm going to try to make this a little more didactic. I don't want to talk the whole time. As it says here, cross only on signal. So I wanted to kind of break the room into 3 groups, and each group is going to try to tackle these questions. If you could have one person in your group be the person who's kind of the scribe, so that they can kind of feed back what your general thoughts are. But we're going to have one group kind of represent the adolescent. I want you to pretend that you're like the person representing them, and trying to determine, kind of, does Mary have decision-making capacity? Should she be able to do this? And then we're going to have another group be the parents. So don't argue too much with each other. And then the law. So we'll have someone kind of looking at the law. And one important question about that I want that group to think about is what laws should be put in place for transgender youth. So I'm interested to see if you could go to the Tennessee State and send out some laws, what would you do? So let's see, I'm trying to think. Maybe we'll have kind of this half of the room in a group, and then this could be parents, and you guys over there can be the law. Okay, so we're going to give about 10 minutes for everyone to think about that. And I'm going to wander around and
I see a scribe emerging. The second he said scribe, I pulled a pen out. It was scribe. The parents.
The parents already agreed for her to be on leave.
right. Mom felt
Just
good
because
about
it was
that because it was
reversible.
reversible. Because
The parents already agreed that she could be on leave for one. Troubled about the
But is it Lupron a hormone?
Lupron and
Lupron is a GnRH agonist that will suppress puberty, but if you stop it, like if Mary changed her mind, which is what Mom was hoping would happen, then natal secondary sexual characteristics would take place. So, yeah.
So the issues where.
So Mom felt more comfortable letting that move forward because there was no semi-reversible or irreversible side effects. And she doesn't see Mary as really understanding the implications of making the decision of doing cross-hormone therapy and having those potential side effects.
How much influence do parents have on children who are like under 18 and have a gender identity thought? And like, is there like some limit of their power in terms of, or is it like physician specific per case?
Well, you're looking to the legal system on some level, right? So can the kid consent for themselves, or do we have to get permission from the parents? I would say parents have a very large role. Again, coming back to just costs and insurance, the way that's going to work, you may have a parent actually who completely disagrees with what's happening but is now absorbing a fairly high cost treatment because of lack of coverage. So they can, as you can imagine, I had one father come in extremely angry because he started getting all the bills, and the child had lied that everyone was on board, and he was most assuredly not.
What happened then?
A very long conversation. But I tried to de-escalate the situation and also explain, in that particular instance, that child was using hormones off the black market and was putting themselves at very high risk because the dosing and everything was totally wrong. By the time the parent left, they realized we really were trying to do the best thing for their child to keep them safe. He still felt very strongly that it's not what God intended for their child, and that they were just confused.
it's difficult on the parent side if they fundamentally disagree.
Well, what would you do? Well, how would you try to reconcile the parents' disagreement?
negotiate.
Negotiate, okay.
Not really a compromise in this situation in terms of, you
It's either
know,
on or off.
can we do something in the middle,
Yeah.
right? You're either doing the treatment or you're not doing the treatment,
Other than
Or you're
waiting.
delaying the treatment.
or delaying the treatment.
To when the child reaches the age when they can make that decision.
And if they're on suppression, then
Then they prolong their state of,
genderlessness.
yes, of being around other teens where they look like they haven't started puberty yet, but they don't also look like they're the gender that they don't identify with. So the trans female in this case would continue to look more like a pre-adolescent male who could then grow her hair out. She would be developing a beard. Her voice wouldn't be deepening. Her Adam's apple wouldn't be progressing. So there'd be a way. Her muscle mass wouldn't be changing. So she could potentially achieve what she wanted in the intervening 2 years.
She would appear as a,
Young female,
yes, one whose puberty is
delayed,
which, I mean, there's a great variation in when
which can be
puberty
very
onset is,
distressing
so.
if you're a natal female, for example, and
And
all
not
your
developing by the age of
classmates
16.
are developing, you don't have breast buds and your breasts aren't developing. And
It's,
yeah,
I've had people have to change schools because they were bullied for those very reasons.
yeah. So
Locker rooms can be brutal.
yeah.
How about refocusing the parents on the child? I feel like sometimes with debates such as this, it becomes about the ego of the parents, especially with the divorce happening and all that kind of stuff. But refocusing, well, what is the primary goal? This is your child. I understand that you both have the belief system that you have, but think about long term, about the mental health, about, I guess, the assimilation of this child into whatever they want to do. I don't know if you've run into seeing if that will help, or bringing in a negotiator, like an arbitrator or somebody to, like psychiatry, say, let's all work as a team for this kid.
Yeah, no, I mean, your point is excellent because I think that is where the focus has to be, because it comes back a little bit to adolescent autonomy, and then also, but you're also getting at something that everyone's interested in, which is the well-being of the child. You know, when parents start to understand some of the risks involved in terms of suicidality and other things, and the potential problems of not helping or assisting in some of these matters, it does kind of open their eyes a little bit to what their child may actually be experiencing. And sometimes that can shift their viewpoint into, well, I don't agree necessarily, like religiously or otherwise with this, but I want my child to be safe and I care about them, and if this is what they really want, maybe I should support them in this. Sometimes you're going to get parents willing to make that leap, and others, obviously, if you can't do it legally, they'll just have to wait.
So a combination of educating parents about the risks of not proceeding for the child, both immediate risks in terms of suicidality and drug use and those things, but also long-term risk in terms of mental health for not making this change or not doing it in a timely fashion.
Right. So this
And
case.
other high-risk behavior, so it might not be suicidal, it may not be self-mutilation, but it could be lots of high-risk behaviors where the child is manifesting all kinds of ways in which they don't care for this body, they don't care for their identity. So they could be, they could become runaways, they could become part of a sex trafficking,
They could
use
obtain their
drugs.
black market hormones, all sorts
Yeah.
of things. They could.
Now, the one thing I will say, this case is more neatly organized than most cases, because most cases a person will have not received a GnRH agonist. They will have gone through their normal natal puberty, and so they'll be in a state of much higher distress about their body and their changes that have happened and are still happening. And so this case is actually a more neatly kind of tucked case, so to speak. But most of the cases I've had in Tennessee, I would say 95% did not get this treatment. Only patients who are now coming in the pipeline with us, now that we're here, will be starting the Lupron to suppress puberty. Most have not had it.
So if they've already been through puberty and then you give them the gonadotropin releasing hormone agonist, can you reverse puberty then?
So in many cases, especially with men, that is the ideal treatment, because it's actually, when you give a man estrogen, it's actually really hard to suppress male testosterone in ongoing levels. So if you really want to give a very effective treatment, you would give Lupron, suppress male puberty, and replace with estrogen. It's very rare though that I can get insurance coverage for that. So what we often are left doing is giving treatment, but then having to give other supplemental treatments to try to get rid of the male hormones. So you can give like spironolactone or other things that are going to make you waste androgens in your urine and block the androgen receptor. But they're fairly ineffective, actually. It really completely suppressing. But then there's also another issue there, which is sexual identity, because a male who identifies as female may still want to retain some degree of male sexual function with their partner, which may be a male or female or both. So you have to kind of discuss that with the patient, and sometimes you're actually titrating to ensure that they actually don't. Some people don't want any function, and other people want some degree of function.
Did these parents agree on the pubertal suppression? How did you get?
They agreed on that one because it was reversible,
okay,
and
right.
Mom felt like, well, he's gonna, because she always uses he, of course. He's gonna realize, like, I want to be like my friends. This is silly. I'm a boy, you know. So that's how she thought it was just gonna be a phase, but then Mary persisted.
And that's also something to bring up with the parents, is the persistence.
Right.
You know, you're thinking, this is going to change, and it has not, and it's been persistent.
Right.
Which is my question, because I read an article in Atlantic like last month, I don't know if you saw it. But
It's a
about
terrible
this
article.
topic, and they were saying that many adolescents
Sorry.
did change their minds later. And
That
what is-
author is completely biased, has a history of writing a lot of articles.
Oh, really?
Yeah, yeah. Jesse Single, terrible. So that's a very biased article.
Yeah. So adolescents who persist for greater than 2 years are they're not likely to desist. But we have had people do it, but it's often been for another reason. So an example would be, I had a patient who was on cross-hormone therapy for a year, but realized, no, I'm not really gender dysphoric, I'm actually just gay. And so then they stopped treatment and kind of assumed a gay identity. But before that, it was easier for them to just simply identify as the other gender.
While they were reconciling what happened.
Exactly. Mm-hmm. So, you know, nothing goes through a textbook, and I'm sure there's all kinds of articles, and people send me all kinds of links that are interesting. But you know, the biggest thing we're trying to do is help these kids navigate these issues and hopefully prevent a lot of the poor outcomes that happen for them from a psychosocial, mental, suicidal point of view. Anyway,
It might be helpful to
probably
have
break into the big group again.
all of them in treatment therapists to sort of reconcile
No,
the feeling
it's not.
that
No, they
what the long-term outcomes could be and what they would want them to be.
Mm-hmm.
And that what they may want more than anything is for the child to be happy and healthy
Right.
than a particular gender.
Right.
And it's not necessary to get both of them to legally consent, but if you want the family to have any sense of functioning, it'd behoove you to do it.
Yeah. In fact, let's make sure we come back to that point, because I want the whole group to hear that. Okay. Well, thank you. Hopefully you guys had a good discussion. I decided to join the parents. I thought that would be a lively group. Okay, so we're going to start with the group that was looking at the point of view from the adolescent. Do we have someone who is acting kind of as a scribe? Yes.
But everybody was participating in the discussion, so I'd invite my group to just sort of chime in. You know, we talked about supporting hormone replacement therapy for short term because it would benefit that individual's mental health until they reached the age of legal accountability where they could then make autonomous decisions for themselves on how much further they wanted to go. But also a conversation about what's right for one may not be right for all. So it's
Mhm.
really a case by case. You know, you can't
Right.
just
Yeah.
put a blanket on all of them.
Okay.
And one gentleman mentioned consideration to withhold until age 25. And he can speak more probably to that than I can. I was just sort of bullet pointing
Okay.
what we were talking about.
And can you?
It's a brain development, waiting for brain development before they mature. Usually it's typically like low mid-20s. And it seems like the more research is done in neuroscience in terms of brain development, that age seems to keep going further and further back in terms of
Executive function.
make a fully informed, conscious decision in terms of cognition, cognitive ability.
Yeah. So this gets to another important kind of.
One consideration.
Yeah, it's an important consideration, right? We're always, as physicians, we want our teens to understand the decisions they're making, decision-making capacity, understanding kind of the normal development of the brain, executive functioning. All these things vary by individual. And so, as was said, every case that I get of a kid with gender dysphoria, I take it as a case-by-case basis. I'm trying to understand all the dynamics of what's happening for that person. Autonomy is something that we usually often respect. In medicine, if this person was a legal adult, we would usually say, well, they have the capacity, they can make the decision for themselves, even if they don't even fully understand it because they're not 25 yet. And we do that in medicine in general, but when that collides with parental autonomy or legal statutes that don't allow that patient to make that decision, then you're kind of left in a different space. It sounded like this group also kind of came up with the unique idea of just proposing, well, why don't we start this treatment short term and then reevaluate if we actually really want to keep going. And maybe that would appease the mother who, at least in this case, was allowing the patient to be on Lupron. And in that case, of course, that was fully reversible. But one other point I wanted to make, though, there is a potential downside, and this is being studied very closely, but obviously if you put a kid on Lupron during adolescence, you're preventing normal exposure to other organs of sex steroids that would typically be there. So, if in this case we suppressed a natal male, so testosterone would not have been around to help with normal bone development, for example. So there are some studies that show concern for decreased bone mineral density. And for that reason, many people are now calling for cross-hormone therapy to be started earlier, not later, for potential side effects for bone health. There's a lot of controversy about it because, when you have a transgender female, are you looking at female bones to determine normal, or are you going back to their natal gender to determine that they have a normal bone mineral density? And so that's where people really get heated at the conferences. Anyway, but there is a legitimate concern that prolonged suppression of puberty during the period where it's meant to happen may have bone effects. So again, these things we're doing are not without potential side effects. Let's hear from the parents group. I know you were taking some notes there.
Yes, so to address the first question about how to reconcile the disagreement with the parents, we kind of proposed negotiation tactics, maybe trying to bring about a common focus, which is the child's ultimate well-being, educating the parents of the immediate versus the long-term risks, such as just really terrible depression, suicidality, completed suicide, and other high-risk behaviors that the patients might, or the children might expose themselves to as a means of reconciling what is going on with the internal struggle that they're living through every day. We didn't fully get to answer the question of consent in terms of ethical versus legal, viewpoint. I have an opinion, I will just toss it out there, my group can disagree with me. I don't know, I like to think I play hardball, but I don't know if that's gonna actually happen. Who's gonna pay the bills? And if that's the parent that you need to get on board, that should be the first target to get that kid what they need. I think in a short-term approach. In a long-term approach, because my focus would be that child, it would not necessarily be all this all the ramifications around it. But in the long term, I think there should be, a way of addressing it. But that's all I'm going to say is who's going to pay the bills for there.
Yep.
So in the state of Tennessee, with both, in this case of a divorced parent, a divorced family where parents both have medical decision-making capacity, they're essentially the same as a married couple who have shared decision-making capacity. So a mother can enter a child in treatment against the father's wishes, and there's nothing that anybody can do about that. Because this is a particularly loaded situation in terms of the impact it's having on the family, they could progress with the treatment because the father is consenting regardless of the mother's desire. Mother is very opposed to it, so it would behoove the physician to see if they could get everybody on board, because it's going to be in the best interest of the child ultimately to have everybody in agreement about what's going to happen. Because even in the cases of trans female, it's a very difficult transition to make. The hormones, natal females have a hard time with their hormones, and it's no different for trans females. That it's going to be a difficult challenge, and to have both parents be able to be present, and emotionally present and supportive will be very important. So a delay may be the best thing to do, to see if we could get everybody to agree on that.
I was going to just say I totally agree with that. In fact, even when a child in my practice has the legal or ethical capacity to make the decision, even without their parents' consent, I still delay for all the reasons she just mentioned. If you do not have the parents on board, it is going to create tension. If there's tension about the payments and the insurance, if there's tension between the parents, or they're seeing the mood swings on the medication, the best way forward is to get everyone involved, informed, and at least on some level willing to support the patient in their decision.
And I wanted to say something about the waiting until they're 25. I mean, there's lots of evidence about executive function being sort of more fully developed, and all of that is true. The only piece to negate that or to argue against it is that there are lots of privileges that are given to people at the age of 16, at the age of 18, at the age of 21, where they're allowed to engage in lots of risky behaviors. No lawmaker said they can't get married until they're 25 because they don't understand the ramifications. They can't enter the military until they're 25 because they don't understand the ramifications. So there's a way in which that, I think it goes back to the autonomy of, do we get to live the life that we want?
Right. And our legal system, our medical system, we're always trying to balance those, right? We're trying to figure out where do we allow decisions to be made, where do we feel good about letting a person make a decision that it's actually not a great decision, like smoking. And so, this is a conflict that we will find in medicine everywhere. But it really comes to the fore in patients who are transgender. Yeah, you have a question?
So if the parent disagrees with the child, and they ask you, what makes you think that the child's fully aware? Like in this case, the child's 11. So is there certain criteria you can provide in terms of, yes, the child is aware and knowledgeable and understands that?
Well, in this case, the child's now 15. They started treatment with the GnRH agonist when they were 11. So they've persisted for over 4 years in gender dysphoria, during which they have consistently met with a mental health professional to discuss what was going on and for ongoing evaluation. So again, as a pediatric endocrinologist, I am relying very much on the mental health arm to go over that component. I am not qualified to do that. And so I'm often talking with or receiving information from the mental health professionals involved. If concerns arise or there's any issues, I often address those with the patients. And then, I will delay if there are comorbid conditions or issues that have come up that put into question decision-making capacity, or that there's some sort of coercion or something else going on. Okay, we're going to run out of time, so let's at least hear from the law side. So we had, is the law sufficiently ambiguous to allow treatment without the parent's consent? And then propose some laws for us.
We said yes, about age
Okay.
And we had a lot of discussion. Laws to be in place was a kind of, we were wondering about in a court of law, if this actually went to court, what would the court expect from a medical profession standpoint to help them substantiate their judgment? And we weren't sure what that would be, but we also wondered if there were any protection for medical providers who would be allowed to provide treatment if they felt like in their judgment and assessment, and like you said, with other collateral that you've gotten in their professional opinion, it was appropriate.
Okay.
So we had some polls. We weren't sure what was in place and what wasn't, but those were some thoughts, and I'm sure some of these guys would have. We all talked a lot.
Any other thoughts before I comment on that? Okay. So my last group, when I did this, they just decided they were the legislature, and they came up with all kinds of laws. First, they came up with universal health care, so that then all the insurance issues would go away. Then they came up with protecting gender dysphoria in all cases in the state of Tennessee, and recognizing it as something that should be protected. So they were very creative, actually. I can't even remember all the things they came up with. By the time I was done, I was like, wow, that's quite creative for a red state. But to get it, to kind of go back to, so, and this has not been changed as far as I know by the current administration, but Obama did put in place several laws about how physicians provide care for transgender youth. They are obligated to not discriminate against transgender or LGBT individuals. If you provide a treatment in one setting, such as testosterone treatment, you're obligated to provide that same treatment in the case of gender dysphoria. So as far as I know, that has not yet been undone or re-evaluated. And so from a legal standpoint, on a kind of more of a national scale, there is a precedent for that. But, like I was going through with the law there, really the state of Tennessee has never really addressed this issue directly. And so you're left with these other statutes to try to determine your course forward. Again, to me, the best thing for all these things is to truly do them thoughtfully, and there really isn't a rush, usually. Sometimes, though, there are significant psychological or other issues going on where I'm very concerned that without treatment, this patient is very high risk. So, for example, I had a patient that was cutting themselves. This was in Oregon. They were cutting their breasts constantly. They were endorsing to their mental health professional that they were suicidal. They had a plan. They really wanted their life. They really wanted to move forward cross-hormone therapy, but their family would not agree and wouldn't pay for it. That was the part where they couldn't move forward, is they couldn't pay for it themselves. And so eventually they went on treatment, and they went from night to day. It's like they were a whole new person. It was really quite extraordinary to watch the transformation of that person. So actually the picture of Mary that's on that slide is Leela Elkhorn. I don't know if you know that name, but that is a patient who is in a fairly strongly religious family who threw themselves in front of a truck because their family rejected them as transgender. So this is how I'm going to summarize our discussion today. There's lots of different ways to look at this question, right? We've got someone looking at, well, what about brain development? We've got someone looking at, well, what legal precedents do we have? Or what should a parent be able to dictate? How much should an adolescent be able to choose? How capable are they in making these kind of important decisions? As physicians, as mental health professionals, or whatever you may be involved in, it's just so critical that we are seeking to understand and then be understood. That we're seeking to build these bridges with people who may or may not agree with treatment and may have very legitimate kind of religious or cultural or other reasons why they feel together and understanding each other. So kind of my practical conclusions as we kind of finish up here. You know, why do we do these kinds of treatment? We really are trying to prevent all these negative psychosocial outcomes in this group. They are a very high-risk group. I've put here people who dissent in this area. People have dissented for various reasons. Some people say, well, you can masculinize a female, but you can't really make them a boy. Some people see it in terms of like body dysmorphic disorder, and so they see it as a delusion. And so some would question treatment because they say, well, why do we treat this different than we would like an anorexic? Would we help a person lose weight that thinks that they're fat when they're not? So you get those kinds of, you'll see those kinds of arguments if you read. There are dissenting views, so I'm perfectly happy with reading and talking about dissenting views. And then again, pubertal suppression with a GnRH agonist. You know, again, it is reversible. Natal puberty will come back. So it is a very nice stopgap to try to let the patient figure things out before they develop natal puberty sexual characteristics that then cause extreme psychological or emotional distress. Again, the bone mineral density is the one question, though, we have there in terms of not wanting to impact that. And then, you know, if someone really truly does transition for their life, this very much optimizes their treatment, you know. For a male that's developed all the other characteristics and a deep voice, I mean, there's just no way I can undo those kinds of things. And then, obviously, as was brought up several times, it does allow the patient to take on the characteristics of the gender to which they identify, which allows them to integrate and feel like they're their own self in their own skin, impacts them emotionally, socially. These kids are very much impacted in schools and the way they're treated by their peers. I mean, peers are so important at this age. So not allowing these treatments does come at the hazard of significant irreversible biological changes and risks. So again, it's a balance of really informing the patient. I literally pull out the guidelines and walk them through it. And then when they come back the next time, I do it again. Because I really do comprehend that some of our teens may not be as fully comprehending of what they're doing. Some people, you know, they've seen it on Facebook or they've seen it in social media. And I'm like, I want it to go a lot deeper than that. So I have delayed with patients where I feel like they're not demonstrating that they're ready and that they understand the magnitude of the decision. And then, you know, for her, this may end up having to be a premature thing. We may have to wait for both parents to be on board. The guidelines would say, though, that it used to be, again, that we would wait till 16, but now there are many people who would use 14 and 15 to start cross-hormone therapy. And again, a lot of people are using the argument about effects on bone as one of the reasons they do that. And then just to briefly touch on this goes beyond pediatric endocrinology. We never get to the gender reassignment portion of the ethics here. But the guidelines are very specific that you have to be a legal adult, 18 or older. However, there are parts of the country where 16 and 17-year-olds are allowed or have received, for example, a mastectomy. In terms of kind of penectomy or other kind of more major surgeries, those are usually delayed for quite a bit. And usually you would want a patient to have successfully navigated cross-hormone therapy and for their gender dysphoria to have persisted and that their mental health professional still feels confident there's no other comorbid condition, and then for the surgeon to agree that the patient's ready to make that kind of life-altering choice. Again, in pediatric endocrinology, we never quite get here because this moves into the adult realm. So that's my basic presentation. Any questions? Yes.
So lots of mental health support for the patient, but what about the family system? If my daughter is slicing her breasts,
Mm-hmm.
my question is, how is that okay with you all as parents? I mean, you're concerned about your daughter wanting to transition, but my God, she's mutilating herself. So do we have mental health support for that whole family system? Can help moms and dads go, what about this is okay for you to allow her to keep doing this? Can we not open doors for conversation to hear what she has to say?
Right. So the answer is I sure hope so. I mean, we struggle to get, honestly, just the adolescent themselves, the kind of mental health follow-up that they need. You know, if they're in some rural part of Virginia.
Their parents, do we not, as a healthcare organization or you as a physician, sort of have an ethical obligation to say to the parents, and while she's in it, you're going to be in it too, or while he's in it, you're going to be in it too?
Yeah, I mean, in my ideal world, every one of these patients, the parents would be just as much involved in what's going on and part of the therapeutic process, especially when those kind of critical issues are coming to light. The parents may not know that this patient has already tried to commit suicide. The parents may not realize that they're coping with alcohol and drugs because they're so depressed about how things are. So we hope, and we try to bring these things up as they come to visit with us, that everyone needs to be involved in helping this person. It's a very complex issue, diagnostically, culturally. It crosses every possible genre. So I would love to see that. I will say some patients do that pretty well. The parents are very active. It's usually the parents, though, that are very proactive and supportive, whereas parents who are dissenting, they're less likely to want to interface with the mental health professional. They see them almost as part of the problem. Yeah. Any other questions?
How big is the population of transgender youth in the area, and how many do you typically see in your practice?
Well, the estimate of the population is about 1% or so, depending on who you read. LGBT community makes up about 4% or so, depending again on which study you look at. But, our experience here is that a lot of people who grew up in this area who are transgender generally keep it to themselves or have not received any kind of treatment or follow-up. It's not usually until they find out that that's actually available that some people will come. I will say that in terms of transgender patients, they often no-show to appointments, and I don't know what all the factors are. Parents not giving transportation, them being nervous about how the healthcare system will interface with them. And so I had a patient just yesterday, or no, actually it was on Wednesday, who was a new patient transgender and they didn't show up. And that's not uncommon. So I don't know if we really know how many there are, but we can just look at kind of statistics to say there's plenty in our area. But I think many of them kind of don't find themselves either knowing there's resources or don't feel like their family would support them in any of those kind of transitioning things. Yeah, Evan.
Yeah, one thing to add, I trained with Dr. Ford in Oregon, and the Oregon health plan is like TennCare. While we were training, then the public healthcare system began covering transgender care across the board, and the number of transgender patients that we were seeing went from about 30 to 300 in 1 year, and it's grown to close to 1,000 in the 2 years since I've left Oregon. And just from my own experience, every time I would talk with a transgender team, maybe 5 other teams that were not getting treatment from anywhere. And some of them were ordering stuff online from Canada, some of them were sort of being treated under the radar, but almost all of them were going without mental health evaluation. It was only the ones who were well plugged in that actually were kind of following the guidelines. Everybody else was finding some other way to self-treat.
Mm-hmm. Right. And you can see how insurance is such a driver, because even in Oregon, it wasn't until we got things like the GnRH agonists and the Lupron approved and things like that, that suddenly everyone started to come to the fore, and now they have a robust program there caring for them, and they have a very accepting and welcoming environment in terms of the forms and everything else, and the bathrooms. Everything is well designed. There's actually a committee working on that for ballot health currently, and I've been giving some advice to them. But there's so much going on with the COPA that it's taking a major backseat. So, all right, that's it. Yeah.